this is the first of 5 sessions. I thought I'd just tell you a little bit about myself so that you know that I've got a bit of expertise around this area. My background is in working mainly in primary care. I did 20 years working in primary care, but I am a registered mental nurse as well as a registered general nurse. While working in primary care, I did clinics for depression, diabetes, dementia, everything really. That's the nice thing about primary care, is you deal a lot with everything. And one of the things that I did do was the physical health checks for people with severe mental illness. And I got so passionate and interested in it because it wasn't happening very well in other practices that I ended up doing a PhD in the subject, hence the doctor title. So I am a nurse. And I've been so interested, I've spent a lot of time with NHS England, Public Health England, Health Education England. I've been on lots of advisory boards and written lots of papers and all sorts of things. So I've got a great interest, and I'm really passionate about everybody learning a bit more about it and actually putting the learning into practical action. Okay, can I have the next slide, please? So I've written this programme for you all. So the first one, obviously, today is why the physical health of people with severe mental illness is our problem. So what I'm going to do is outline why we should be thinking about it. So not just the people that are employed to do physical health checks within your teams, but everybody within the team. We should all be thinking about it all the time. And then the next session, we'll be looking at keeping healthy, because often when we talk about physical health in this group of people, clinicians are quite often thinking about physical illnesses, and actually physical health is physical health, and the same problem happens in general fields as well. When people talk about mental health, they're really talking about mental illnesses. So we're just going to try and look at the difference and being sure about what it is we're talking about. The third session is supporting somebody with severe mental illness to be healthy. So that'll be looking at what you can do as individuals and as an organisation to support people that you're looking after to be healthy mentally as well as physically. And then the fourth session is the health check. I've put it quite far down the list because though it's really, really important, it's kind of a really small part of the physical health of people with severe mental illness. It's just one small thing. And I think with the world we've had at the moment, having, you know, sequins and quaffs and things, it kind of has become, that's it, you know, you do the health check and tick the box, and that's physical health sort of done and dusted, and we can just get on and forget about it. And then for me, the physical health check is kind of just the starter, it's the assessment, and then we'll be then looking at what we do next. And then the last session is really kind of be over to you lot to look at thinking about what you can do within your organisation to help people with severe mental illness become part of your everyday care. And the thing I'm really kind of pleased with that I've come into this team to teach, the early intervention team, is that I think you guys are probably the most important people when it comes to giving the message of being healthy, you know, getting these people early, because people who've had an illness, a severe mental illness for a long time and they're a bit older, it's kind of almost a bit too late. Obviously, you can always improve health, but you're going to have the most impact kind of right at the beginning and getting people into good habits. Okay, so if we have the next slide. Thank you. So the objectives for today are for you to understand why people with severe mental illness are more likely to have a physical health problem. I'm sure a lot of you are aware of that, but we'll just go through that and make sure that we all know. For you to be aware of the physical health problems experienced by this group that can be prevented, and you'll see that most of the problems can be prevented, and that's why we should get in early. And then recognise that you should consider the physical health of people with severe mental illness in your care. And maybe that sounds really obvious, but I don't think as a whole, in general, that we always do. And there's kind of a lot of things that we can be doing. So I'm just going to keep saying next because some of these have got animation. So people with having physical health is our problem because people with severe mental illness are more likely to die prematurely. So they're more likely to die from a physical illness. And the mortality rate is 25 up to 25 years earlier than the rest of the population, which is shocking really in this day and age. And where you and I are living longer, this kind of group's mortality is staying quite static. And what's really sad is that, you know, physical health has been on the agenda of NHS England and all the trusts and primary care for about the last 13 or 14 years. And in that time, that premature mortality has not gone down at all. So, and in fact, the gap is getting bigger because our lives are getting longer and this group's aren't. Next slide. So they're more likely to have a preventable condition. So I've listed them here. There's respiratory disease, sexually transmitted infections, sexual dysfunction, obstetrics, osteoporosis, cancer. You can see them all there. And I'm actually going to go through all of these individually and do a little bit of explanation around it. So what we want to do is actually prevent people getting these conditions rather than helping them to manage them or treat them. Okay, next point. This group are more likely to lead unhealthy lifestyles. So they smoke a lot more than the rest of the population. They have a poor diet. They don't exercise as much as the rest of us. Some of them have a high alcohol intake. They might misuse drugs and they might engage in unsafe sex. And all these have repercussions to the physical health. Next point, please. And they experience diagnostic overshadowing. And so I'm sure, as you are aware, that what that means is that when a person with a severe mental illness goes to see a healthcare professional and they talk about their physical symptoms, often these aren't investigated or treated and they're put down to their mental health problem. And you might think that might only just happen, you know, within a GP setting or in a hospital setting, in a general setting. But actually, I've seen it happen in mental health settings as well, and it's really kind of sad. And there's lots of evidence to show that's the case. Okay, next point. They're more likely to be prescribed medication which can have a negative effect on physical health. So, for example, their antipsychotics can cause weight gain, raise glucose, sedation, and all those things are going to have a negative effect on their health. And there are other medications that they might be prescribed which could also have a negative effect as well. Next point, please. And I'm sure, as you are well aware, they're more likely to live in poverty. And if somebody living in poverty is more likely to have poor physical health in turn. OK, so that's a good reason, I think. Then the next slide, please. So there's kind of a lot of other reasons as well. So if we look at the genetics of somebody with a severe mental illness, so this is despite their treatment or anything else, they're more likely to have a low HDL. So that's your high density lipoprotein or your good cholesterol. And that good cholesterol is protective against cardiovascular disease. So somebody with severe mental illness already doesn't have that protection. So that's something to bear in mind. They're more likely to have a raised blood glucose. And again, this is a genetic factor. Despite medication or diet, they're more likely to have a raised blood glucose. And they're more likely to have low lung function values. So that kind of baseline, before you even talk about treatment and lifestyle, they're already, you know, in a lower position than the rest of us. OK, the next point, please. They're more likely to have poor motivation, and I'm sure you're well aware of this for the people that you look after. And often you hear people say, well, they don't want to, they can't be bothered. That's the kind of thing I've heard in primary care and unfortunately with mental health professionals as well. And actually, we know it's part of their illness if they have something like schizophrenia. This is a symptom of their illness. It's due to their mental health problem. Therefore, it's up to us as mental health professionals to kind of treat that, help them with that poor motivation. Next point, please. And again, another issue which makes it hard for them to, go to appointments and buy the right food and plan their care is due to their mental health problem. Next point. So if you've got a severe mental illness, you're less likely than the general population to receive support to change unhealthy behaviour. And this is despite evidence to show that people with a severe mental illness want to change their behaviour, and they're just as capable of changing it if they get the right support. But they're okay, so just on that last point, I was just saying that they're less likely than the general population to receive support to change unhealthy behaviour. And I think this is shocking, really, because what we can see is that they need more support and can do it if they have the right support, but it just isn't in place in the care provision. Okay, next point. And again, a stigmatizing thing, they're less likely than the general population to receive a medical examination and intervention. So if two people go in to see the doctor with a sore leg, the person without a mental illness is more likely to be asked to, take the shoes and socks off and get that examined than somebody with a mental illness, and they're less likely to get given the treatment. And though that sounds shocking and hard to imagine, it does happen. Okay, next point. And again, this is kind of repeating the diagnostic overshadowing thing that physical symptoms are often attributed to mental health problems. So the early intervention that they need isn't offered. So that problem gets worse before it's actually given any treatment. So these are the preventable physical conditions that we're going to go through. And why I've picked these is because researchers have looked at the conditions that people with severe mental illness are much more likely to get than the rest of the population. So we're going to go through each of them in turn. Okay, so next slide. So for the first group of conditions is respiratory conditions. So tuberculosis, I've added this one because the research tells us that people with schizophrenia are much more likely to have tuberculosis. This is something that's spread it's spread by droplet sprays, and it's spread when people live in close contact with each other or they live in not very good conditions. And it is on the rise in this country, so it's something that you might want to be aware of. So kind of the symptoms that you might see a cough that's present for more than 3 weeks with phlegm, and it actually might contain blood, though you might not see that. And often people think it's a smoker's cough, and often that can be ignored. They might lose weight, have a high temperature, sweating at night, be tired and fatigued, lose their appetite, and then they'll have these swollen glands. So obviously tuberculosis is very easily picked up. They would have a chest X-ray and they would be diagnosed. The treatment is antibiotics, and they have to have them for a very long time. It's quite a big thing to take on, but actually it's very easily spread, so it's something that does need treating. Okay, next slide. So chronic obstructive pulmonary disease, you might hear it classed as COPD, and this is a very common disease in this group of people. In fact, it's one of the most common diseases in people with severe mental illness, and it consists of two conditions really. So bronchitis and emphysema. So bronchitis, the airways are affected, so they're inflamed and they get lots of mucus. So if you see the little picture on the top right hand side, you can see that's an airway that's kind of got inflamed and it fills the mucus. So the passage where the air goes through gets really narrow, so it makes it difficult for the air to go in and out, and that's why people get breathless. And then with emphysema, the sacs of the alveoli sacs, which is where gaseous exchange takes place, a breakdown. So again, there's another sort of biological function that isn't working so well. So there's two reasons why they're breathless. Okay, next slide. So the symptoms that you want to be looking out for: increased breathlessness when active, a persistent cough with phlegm, and frequent chest infections. These people get chest infections very often. Okay, next point. So I think I've already said that before. So systematic review, that means that researchers have looked at every piece of research there is on the subject. So they've looked at every piece of research with COPD in people with severe mental illness and put it together, and they found that it's the most prevalent disease in this group of people. So next point. So I'm just going to ask you, why do you think people with severe mental illness are so prone to chronic obstructive pulmonary? And then the other reason, if we just put the next point up, please, is that they're less likely to have the health checks to look out for the problem as well. Okay, if we have the next slide, please. So sexually transmitted infections, I don't know if this is something that you've seen as practitioners, really kind of increased in this group. And I've just listed here all the different illnesses that they might pick up from their activity. So the research tells us that STIs are more prevalent in people with severe mental illness compared to the rest of the population, and it's even more prevalent if they've got a substance use disorder as well. So this next point, I think, is a question. Why do you think somebody with a severe mental illness might be more likely to get an STI? Just click. Right, so some of those you said. So poor decision making about what is safe sex. I mean, that happens in the general population as well. The increased likelihood of sex with an injecting drug user, the hypersexuality, which somebody did say about when somebody's got bipolar disorder. They might not use a condom. The vulnerability was mentioned, and they might sell or swap sex for cash or drugs. And there are other reasons, but they're kind of the most obvious ones. So if we know this, my point here really is, if we know that this can happen in this group of people, it's about teaching them good habit. If you tackle this early and get people into good habits and give them the knowledge, then they're less likely to get the STIs in the future. And also there's the emotional side of it as well. Okay, if we have the next slide, please. And the next point. So we're talking about erectile dysfunction here. And they usually, erectile dysfunction is obviously impotence. It's usually caused by a medical condition. So often when we think about erectile dysfunction as somebody with severe mental illness, the first thing we think about is the medication. So actually for your team, because you're seeing young people, it very well may be the medication. But for some of the maybe the older clients, we need to think about, have they got heart disease or diabetes, where it's really, really prevalent? Have they got high blood pressure? Have they got raised cholesterol, because that will clog the arteries of the penis? Less likely the low testosterone in this group of people, but it still could be a cause. Okay, let me just put the next point up, please. And then we think about the drugs, and it's not just the antipsychotics, unfortunately. Some of the other drugs that they might be prescribed for their mental illness and their physical conditions can cause erectile dysfunction as well. But also some of the drugs they take themselves. And this is, you know, conversations worth having. So alcohol is one, cannabis and other drugs, and then smoking. And we've already, you know, ascertained that this group smoke a lot, and actually it might be the cigarettes that are causing the problem. And as you can see on the slide, that it's the nicotine constricts the blood vessels which supply the penis. So again, that could be a really good conversation to have with somebody when you're trying to get them to reduce their smoking. You know, if they've got some erectile dysfunction, that might be the cause. So it's not always the antipsychotic. So it's about careful questioning. When did you have this issue before you started the drug? So it's just something to consider. Okay, next slide, please. So now we're looking at obstetric complications. So obstetrics is when we're talking about pregnancy and childbirth and the period after childbirth. And there's a really high incidence of complications in people with schizophrenia. I'm sure there is with bipolar disorder, but the research is looking at people with schizophrenia. And there's no definitive association between the use of antipsychotics during pregnancy and an increased risk of birth defects or other adverse outcomes. But that's only because the research hasn't been done, because you can't do research on pregnant ladies, you know, give them drugs and not drugs. Yeah, so I've just put a few points up there. There's lots of points, and I think the difficulty is, and you probably know this better than me, that often these women don't present that they're pregnant in the early stages, when you would be doing a lot of the scans and the care and the education. So, and they don't go to all the appointments, and as you say, smoking and alcohol and poor diet and still eating the stuff that you're not supposed to eat, all that kind of stuff. So another one is osteoporosis that this group are more likely to get. So it's osteoporosis weakens the bones and it makes them more fragile and more likely to break. So I've got a little picture here of a healthy bone and an osteoporotic bone, and you can see that it's much more fragile. So if somebody has a fall, they're more likely to break the hip or their wrist. So the sedentary lifestyle, so that's a little bit different from the lack of exercise. Just sitting about and not even moving very much isn't going to let your bones get strong. They're not doing the formal exercise. The smoking, alcohol and drugs can cause it. The poor diet, as somebody said. The decreased exposure to sunshine, which is not just a problem for people with severe mental illness, it's actually become a problem for the whole population, but this group in particular, because in general they don't go out so much. A rare one in polydipsia, inducing electrolyte imbalance. So we don't see this so much now, but I don't know if any of you are as old as me that remember when people were in institutions, about 17% of people with schizophrenia had a condition where they wanted to drink all the time, and this obviously caused them to wee a lot, and then if you're weeing a lot you get rid of all the electrolytes, and then if you have a low potassium, that obviously can cause an issue. And then as somebody already mentioned, antipsychotic drugs can increase prolactin levels, which cause problems, which is why we think about testing for raised prolactin. But we'll talk about that in session 4. Okay, next slide. Right, so cancer, this is an interesting one, because what the research has told us, that people with schizophrenia are less likely to get certain cancers, but they're more likely to die prematurely from the cancer, and they're more likely to have metastases when they're diagnosed, so that means it's already spread. And then they're also less likely to get screened for the cancer, and they're less likely to receive specialist interventions. Okay, so I'm thinking that this might be something you've seen, maybe not so much with the youngsters, but those of you who've been in the service for a long time. Is this and the diet? I think some of the things I've seen, and I don't know if it's the same with your patients, the amount of kind of fizzy drinks they drink.
Yeah.
Full sugar, 3-litre bottles. So that's, you're just adding sugar to their teeth the whole time. So again, also, yeah, the hygiene, not brushing their teeth, not cleaning their teeth. Yeah, it's a very sad state of affairs. But again, if we can give them good education and prevent this happening, that's a good start. Okay, the next. Right, so metabolic disease, this is something that a real good proportion of your patients, if they haven't got it already, will develop, and it's kind of a hidden thing. So the World Health Organization define it as this, that they have to have the first one, either type 2 diabetes, which is 3 times more prevalent in this group anyway, impaired glucose tolerance, which you wouldn't necessarily see, or normal glucose tolerance with insulin resistance. So that means that the insulin isn't working so well. So they'd have that. So they might have that and you wouldn't know. And then together with 2 or more of the following, so either high blood pressure, abdominal obesity, or a BMI of over 30, and that's a real good proportion of people with severe mental illness, unfortunately, because of the diet and the medication. The low HDL cholesterol, so that low good cholesterol, which we've already ascertained can be low anyway. High triglycerides, so triglycerides are like fatty acids, they're part of the fat in the blood, and that they get high if you drink lots of alcohol or you eat lots of sugar. So people are having lots of fizzy drinks that are more likely to have those high triglycerides. And then microalbuminuria is microprotein, so it's the really first early signs that there's some problems with the kidneys. And again, this isn't a test that you would do on a regular basis. So what I'm saying to you is that lots of your patients might already have metabolic syndrome, and we don't know. And if they do, then they're at really high risk of cardiovascular disease. Okay, next slide, please. So I just thought I'd explain diabetes, and I apologise if I'm teaching grannies to suck eggs, but there's 2 types of diabetes. So the type 1 is kind of what we might hear called diabetes of young people, because it's not a metabolic disease, it's an endocrine disease. It's a disease of the hormones. So what's happened is the pancreas doesn't produce enough insulin, and that usually happens because they've had like an infection when they're a child, and the cells get wiped out. And because it's not producing enough insulin, the only treatment can be insulin injections. Or eventually they would die. So your typical person with type 1 diabetes would be very slim, and you can actually have type 1 diabetes and develop type 2 diabetes later on down the line, because they're very different conditions. So about 15% of the population have type 1. Probably the one we want to be thinking about is type 2 diabetes, because this is a metabolic disease. So what happens there is the cells of the body do not respond properly to the insulin produced. So that's called the insulin resistance. So they're the pancreas is working fine, but the body isn't using the pancreas, using the insulin so well. So what happens is the pancreas starts to make more and more insulin until the end it kind of packs up and it doesn't produce so much. So when that happens, they might have to have insulin as well. And the problem with insulin is it makes you put on weight. So that's a consideration when people with diabetologists and diabetes nurses are thinking about treatment. So in the first throes of the disease, it can be managed with improving lifestyle and with certain medications. But again, if the pancreas is packed up, then you might need to go on to insulin. And then you can also have gestational diabetes, which happens when somebody's pregnant. So again, I think what we're really considering is type 2 diabetes, but again, you might see the others, obviously. And I've got this little picture here where I'd normally go around and ask people questions, but I won't. As on the computer today is looking at the kind of long-term effects of having diabetes. So neuropathy, that little first circle is supposed to be nerves. So neuropathy, when there's a disease of the nerves, nephropathy, so the kidneys can get affected. Cardiovascular disease, that's the heart, so we're going to talk about that in a minute. And then people can get issues with their eyes, so they can eventually go blind in the extreme terms. But actually, when somebody's first diagnosed with diabetes, they might have some issues with their eyes, which then get corrected as their blood sugars come down. And then problems with feet. So we need to check people with diabetes. They should have a foot check every year because they can develop, they have lack of sensation and stuff like that, so can develop sores and things without realising. Okay, next slide. So I just thought I'd explain to you what cardiovascular disease is. So basically all it is having a decreased blood flow to the heart, and that can be because of thrombosis, which is a clot. So when the blood gets all more viscous and it's got bits of cholesterol and stuff going around it, it develops a kind of lump or a clot, and then that clot will just block a vessel, and that's when you get you know, an event because the vessel is blocked. Or atherosclerosis. I don't know if you can see on the slide, that's a kind of picture of atherosclerosis, which is just a thickening of the lining. So it gets thicker and thicker, the plaques are put down, and then by the end it gets almost totally blocked. And the stenosis thing means when it gets kind of to that stage, not only does it get blocked, it loses its sort of stretchiness, it gets hard. So where the blood could push through and the vein might stretch, it can't. So obviously with that pressure puts the blood pressure up. So that's when we talk about having high blood pressure, that is why. Basically it's just clogged up arteries. Okay, next point please. So there's 4 types. So basically this clot or thickening of the lining can happen in 4 different places, causing 4 different diseases. So the first one is coronary heart disease. So that can be, you know, your heart attacks and your heart disease. Then if it's in the brain, somebody would have a stroke. Peripheral arterial disease, it affects the legs. That tends to be the one that really happens a lot in smoking and diabetes. So you see people having to have amputations because basically the blood flow dies down to the legs. And then aortic disease is, the aorta is the great big kind of vessel right in the middle of your body, which feeds the whole body. So if people have aortic disease, it's pretty grim. Okay, next slide. Thank you. So when we talk about cardiovascular disease, we talk about it in risk factors, and when we're measuring people's risk, we look at risk factors that can be modified. But I just thought we'd just quickly look at what factors can't be modified. So what are the things that may make somebody more likely to have cardiovascular disease that you can't change? Does anybody know? Okay, so we're talking about age. So obviously as you get older, your risk of having cardiovascular disease just goes up. There's not much that we can do about it, even if you have a facelift. And when we're looking at, you know, preventing cardiovascular disease, I don't know if people are aware of like the NHS health checks. When they first started doing them, they looked at people who were the most risk because they can do a risk score, and obviously the first people they took to were the elderly. And the next one is gender. So if you're a man, unfortunately, you're more at risk. And then ethnicity. So Southern Asian people are more at risk just genetically from cardiovascular disease. Okay, next slide, please. Okay, so the modifiable risk factors for people with CVD are significantly increased in people with mental illness. So when we're talking about modifiable risks, it means things that we can change, things that we can make better. So I'm going to ask you what they are, but I'll put the first point up to start you off. Okay, so just put the first one. Yeah, great. So these are in order of what would make the most difference to the person. So if we can help somebody with their obesity, their high blood pressure, diabetes and cholesterol, so these are conditions basically. So if somebody loses weight, they're treated for their hypertension, they get their diabetes under control with medication, they take their statins, their risk of having a cardiovascular event is greatly reduced. So why I think this is important is because part of your role can be to encourage people to take the medication that they're prescribed for the physical illnesses. That's kind of something that could really put years onto their life, and it's a very small thing for us to do. And I feel that if we can encourage people and help people and educate people and explain to people that, you know, the treatment for these conditions is important, that can make a massive difference. Okay, so there's a little pictorial clue. What might be the next risk factors? Great. Yes. Okay. So, Sue, can you put the next point up? So again, I've put these in order of what would make the most difference to a person's health. So smoking. So if you think back to all the conditions that we went through, nearly all of them were caused by smoking. So diet will make more difference than exercise, and then alcohol. So these are all the things that will make a huge difference. But again, if you were the one picking, but obviously when we look at behaviour change, which we're doing on session 3, it's really up to the patient to look at which one they tackle first. Okay, the next point. So stress. So there's nothing to tell us that this group of people are more stressed than anyone else, but they actually don't deal with it as well. And when somebody's stressed, that can cause all sorts of issues with their physical health. One thing they produce is a hormone called cortisol, which then puts up the blood pressure, etc., etc. They don't eat as well, they don't manage their life as well. So again, this can make somebody more likely to have a cardiovascular disease. The next point, please. The diagnostic overshadowing, which we've talked about already. So again, if people aren't getting the right care, then it's not going to be tackled. The next point. So the antipsychotic medication. So what we know about antipsychotic medication is that it increases the person's appetite, therefore increases their weight, and some of the medication does it drastically, as you know more than I. Medications like olanzapine and clozapine, and they also can put up blood glucose. So again, these are all precursors to cardiovascular disease. And the next point. And I said already, poverty. So if people aren't eating well, they're more likely to eat fatty foods and stuff. So again, these are all the risk factors that something can be done about it, that we can prevent. Okay, come on, next slide, please. So I'm going to put an example up now, and I want you to consider the physical health risks. So I'm going to put it up in a second, and then you're going to go into breakout groups just for 5 minutes. And what I'd like you to do afterwards is, so you're going to have to choose somebody to feedback, but just one point that you feel is really important. So let me just put up the scenario. So we're looking at John. He's 26. He was diagnosed with psychosis 4 years ago. His psychosis is well controlled, but he has difficulty with motivation and organisation. He lives alone in a bedsit and he sees his mother once a month when she comes to do his washing. He has a lady friend who spends the night with once a week. She lives in the bedsit opposite him and also has a mental health problem. He does not work and spends most of the day in bed. He only goes out to the shop over the road when he needs food and cigarettes. So the community mental health nurse visits every fortnight to give him his Depo injection as he won't go to the GP surgery. She's noticed that the bed sit is damp and dirty and does not look like John has washed himself or his clothes in a while. Okay, so what I'd like you to do is have a look at what physical issues might occur in this scenario. Physical health risks that John might be experiencing because of his lack of physical activity. This could lead to osteoporosis, obesity, cardiovascular disease, diabetes, hypertension, some cancers, stroke, sleep apnea and infertility. Because of his poor nutrition and diet, he could get malnutrition, dehydration, which in turn causes headaches and urinary tract infections. Obesity, high cholesterol, diabetes, heart disease, cancer, gallstones, gout and other health problems. The smoking could lead to cancer, cardiovascular disease, respiratory disease such as COPD, periodontitis and erectile dysfunction. The lack of medical self-care or neglect, as you did say, can lead to minor ailments or injuries becoming more serious, dental problems, skin rashes, sores, foot problems, infections and accidents. And then we need to look at his sexual health. Is John taking precautions to avoid STIs and pregnancy? Does he have any sexual problems, such as reduced libido, erectile dysfunction, spontaneous ejaculation or priapism? That's a prolonged erection, which can be caused by the medication. And other physical side effects from his medication, so constipation, drowsiness, increased appetite, weight gain, sexual problems and muscle stiffness. So there are a lot of health risks there. So just recapping really, why the physical health of people with mental illness is our problem is that most of the physical health problems are preventable and they relate directly from either the mental illness itself or the medication that we give them to treat it. So it is our problem. Next point, please. The other healthcare professionals that are around might not have the time or the expertise to support people with mental health problems, to promote good physical health. So people in primary care might call them in for they're only responsible for their annual physical health check. And they kind of work in a reactive way rather than a proactive way. And a lot of them haven't had any training. Public health people may not have any mental health training. So kind of we have got, we've got a responsibility to do this in the light of some of the cuts, you know, the gaps in the services as well. Okay, next point. So even if care is provided by another agency, so if somebody's been referred to a weight clinic or a smoking cessation group or an exercise class, what the research tells us is they might require additional support to engage and keep motivated to attend. So the research tells us if you just refer somebody off to another class, if they've got a severe mental illness, they're quite likely to drop out quite quickly, and they are more likely to attend if they have a person that kind of checks in with them. So if it was you, for example, and you checked in with them and said, you know, are you still going? How are you getting on? And that kind of thing, they're more likely to keep going with it. So that's something to consider if you are referring people on. And next point. And basically, there is a lack of appropriate services to assist people with mental illness to improve their physical health. I mean, that varies around the country, and I've seen lots of different ways of people trying to deal with it. So therefore, if that person's in front of you and they're under your care, obviously you just have to do the best you can, and be mindful that if you're not doing it, maybe nobody else will be, which is kind of a sorry state of affairs, but it is the case. Okay, the next slide.